Welcome to the Deep Dive. Today we're really diving into a critical part of healthcare, maybe one you don't think about much, podiatrists, and their essential role on vascular teams, specifically for patients, whose limbs are at risk.
Yeah, and we're drawing heavily from Rutherford's vascular surgery, the 10th edition, so solid sources here.
Absolutely, and it's kind of amazing when you think about this isn't new.
Not at all. Specialized foot care, believe it or not, goes way back. We're talking ancient Egypt, like 2400 BCE.
Wow, that really puts it in perspective. It shows how fundamental foot health has always been seen.
Definitely. And it wasn't just, ordinary people. Think about figures like Napoleon or even Abraham Lincoln. They relied on foot specialists, too.
That really underscores how vital healthy feet are, no matter who you are.
Exactly. And one thing you'll notice as we talk, the names change. Sometimes it's podiatrist, sometimes chiropodist, podolog, podologo.
Right. Different names, but all focused on the foot and ankle, though maybe with slightly different jobs depending on the country.
Precisely. The scope can vary.
Okay, so let's unpack this. Our mission today, really, is to get why this teamwork, podiatrists and vascular surgeons, is so crucial. We're talking about saving limbs, preventing amputations, especially for folks with diabetes. Understanding what podiatrists uniquely bring to the table.
Right. So let's start with the basics. What is a podiatrist? Well, they're a healthcare professional specializing in the foot and ankle, both medically and surgically. But like we said, what they can do exactly differs place to place.
And the history is pretty interesting. I saw that in the UK, way back in the 19th century, there was this guy, Louis Durlacher, surgeon chiropodist to royalty, actually.
Yeah, he was a big early voice pushing for it to be a recognized, protected profession.
And then in the U.S.
New York was the first state to actually license podiatrists. That was way back in 1895. Think about that. Formal recognition over a century ago.
That's early.
And then came the professional journals, which are always key. The Journal of the American Podiatric Medical Association started in 1907, and the Chiropodist in the UK in 1914, really building the field.
One name that pops up here is William Skoll, Dr. Soul.
Ah, yes. He actually had an MD, a medical degree.
Right. But he saw this gap in the U.S., didn't he? Especially compared to maybe what he knew from his family's shoemaking background in Germany.
Exactly. He recognized a need for specialized foot care products and knowledge. He built this massive company based on his inventions, arch supports, things like that. He really blended medical insight with practical foot care solutions.
So that blend seems key to the profession. What about the training now? If someone wanted to become a podiatrist today, say in the U.S.?
It's intense. You're looking at 4 years of undergrad first, then you have to take the MCATs, just like for regular medical school.
Okay.
Then it's another 4 years of podiatric medical school, leading to a DPM, Doctor of Podiatric Medicine degree. And after that, there's a mandatory 3-year residency. It used to vary, but now it's required everywhere in the U.S.
Wow, so that's 11 years after high school, minimum. That's a serious commitment. And they get a really solid medical and surgical grounding in the lower limb.
Absolutely, and it doesn't have to stop there.
Right, I saw mentions of fellowships.
Yeah.
For specializing even further.
Exactly. Things like diabetic limb salvage, trauma, reconstructive surgery, really honing specific skills. And then there's board certification.
Like the ABPM or ABAS, American Board of Podiatric Medicine and American Board of Foot and Ankle Surgery.
Precisely. Those signal advanced expertise. And there's even a specific certificate of added qualification, a CAQ, in amputation prevention and wound care. Really targeted.
So the U.S. model sounds very comprehensive, quite surgical. How does it compare to, say, the U.K. or Commonwealth countries?
It's a bit different. The standard route there is usually a Bachelor of Science, a BSc in podiatry. That's typically 3 or 4 years.
Okay.
Now, if you already have a health science degree, you might do an accelerated postgraduate course like a master's, MSc, or sometimes a DPM. But the UK DPM usually needs that MSc first and takes around 6 years total.
Okay. And after the degree?
There's a year-long preceptorship, sort of like a supervised practical year.
So maybe the U.S. path integrates that extensive surgical training a bit earlier. Does that affect how they collaborate with vascular surgeons?
That's a fair point. The US DPM generally starts with a broader surgical scope, but then in both systems you see podiatrists specializing further in musculoskeletal diabetes and vascular rheumatology skin issues.
Right, covering a lot of ground in the foot and ankle.
Definitely. And you see variations elsewhere, too. Australia seems to be moving more towards the U.S. model. Canada's interesting. They often have a 2-tier thing. Podiatrist is usually reserved for the DPMs, often U.S. trained, while chiropodist might refer to diploma-based training. So qualifications and scope really can vary.
Okay, so let's talk scope of practice then. What can they actually do? You mentioned it varies.
It really does. In the U.S., it's state law that dictates it, so you'll see some differences state by state.
Okay. But generally,
Generally, they can do full history and physicals, order labs, imaging tests like X-rays or MRIs, prescribe medications, admit patients to the hospital.
and surgery.
Yes, surgery. That includes things like partial foot amputations. In a few states, their scope might even extend to below-the-knee amputations, though that's less common.
Wow.
They can also harvest certain types of grafts, that's tissue taken from the patient themselves, autologous grafts from just above the ankle to use lower down, and they can supervise hyperbaric oxygen therapy.
Wait.
That's the treatment where you breathe pure oxygen in a pressurized chamber, helps with healing certain types of wounds.
Got it. But there's another layer, right? The hospital itself.
Exactly. Just because something is legal in a state doesn't mean every podiatrist can do it in every hospital.
Yeah.
The hospital's medical staff grants specific clinical privileges. It's about ensuring standards at the facility level.
Makes sense. What about the UK system? You said it's more standardized.
Yeah, because it's centrally regulated by the Health and Care Professions Council, the HCPC. So practice is more uniform across the UK.
Okay.
And they have this kind of two-tier system. You have registered podiatrists, and then you have podiatrists practicing podiatric surgery.
So the surgeons have extra training.
Significant extra training, yes. Beyond the standard podiatry degree. This lets them handle much more complex cases.
Like what kind of cases?
We're talking complex limb salvage, trying to save the foot and ankle from amputation, dealing with severe forefoot, rear foot, ankle problems. They can do both minor and major amputations if needed, and advanced reconstructive surgery, like for Charcot foot deformities.
And you mentioned they work closely with vascular surgeons in the UK.
Very closely. Often side by side in multidisciplinary clinics or operating rooms. It's really fostered a strong collaborative culture there.
That collaboration seems key because they're often seeing the same patients, aren't they?
Absolutely. Podiatrists are trained to do initial vascular checks assessing blood flow, looking for problems. They often order the first non-invasive tests, like Doppler ultrasounds.
Which might lead to a referral to a vascular surgeon?
Exactly. And flip side, the vascular surgeon relies heavily on the podiatrist's expertise for wound care, especially when healing is slow because of poor circulation, or if a patient needs foot surgery but has iffy blood flow. That's super common with diabetic foot issues.
So really complementary skills. Each brings something vital. Now, beyond the clinic, podiatrists have made some major research contributions too, right? Helping us understand these problems better.
Oh, absolutely. Especially thinking back to the 1990s when diabetes rates were really climbing. The group at the University of Texas Health Science Center in San Antonio did some groundbreaking work.
Like what?
Well, they developed and really rigorously tested the University of Texas ulcer classification system, the UT system.
Okay, what does that do?
It grades foot ulcers based on how deep they go and then stages them based on whether there's infection or ischemia that's reduced blood flow.
Yeah.
The key thing is it doesn't just describe the wound. It directly correlates with how urgently you need to act and how likely an amputation might be. That's incredibly powerful information for any doctor treating these wounds. It's used worldwide now in clinics and research.
That sounds like a fundamental tool. Did they develop other things too?
They did. They also came up with the University of Texas foot risk categories. That was sort of a precursor to the risk systems used now by the American Diabetes Association and the International Working Group on the Diabetic Foot, the IWGDF, helps flag high-risk patients before they get ulcers.
Proactive identification.
Exactly. And importantly, podiatrists were right there with vascular surgeons co-developing the WIFI classification.
Right.
Stands for wound, ischemia, and foot infection. It's another system to grade how severely a limb is threatened, helping guide decisions about needing things like bypass surgery or angioplasty. That co-development really highlights the teamwork.
Really impressive collaboration impacting assessment. What about Charcot foot? That severe diabetic complication.
Yes, podiatrists have been central there too. There are a few classification systems. The Sanders-Freiberg one looks at the anatomic location where the breakdown is happening.
Okay.
And then another one, the Rogers and Bevilacqua classification, kind of mirrors that UT ulcer system depth, ischemia, infection. And it's been shown to actually help predict the risk of amputation in Charcot patients.
So these aren't just academic exercises. They have real clinical value in predicting outcomes.
Precisely. They guide treatment and help manage expectations.
Hmm.
Podiatrists have also done crucial work looking at epidemiology,
Yeah.
looking at population trends. They've highlighted the really significant racial and ethnic disparities you see in who gets diabetic foot ulcers and who ends up needing amputations. That research is vital for trying to address those inequalities.
Absolutely critical.
And their training really emphasizes biomechanics, how the foot and body move. That deep understanding is key to figuring out why diabetic feet are so vulnerable, the combination of nerve damage or neuropathy.
So they can't feel injuries.
Right. Plus, abnormal pressures from foot shape changes and just the repetitive stress of walking. It all combines to cause ulcers. Even small stresses add up when you can't feel them.
Makes total sense that understanding the mechanics is crucial for prevention. And this research isn't just published in podiatry journals, is it?
Not at all. You see podiatrists publishing important work in major journals like JAMA, the New England Journal, the Lancet. It shows the quality and relevance of their research to the broader medical world.
And they were involved in the global vascular guidelines, too.
Yes, co-authors on those guidelines, which are endorsed by their own association, the APMA. It really shows they're integral players in managing vascular disease, especially in the lower limb.
Okay, this paints a picture of a profession that's really active in clinical care and the research driving it. Let's shift now to how this all comes together in team-based care.
Right, because caring for patients with chronic limb-threatening ischemia CLTI, that severe lack of blood flow,
Yeah.
it's incredibly complex. And historically, without clear, coordinated teams, outcomes weren't always great. It was challenging. This is really where that synergy between podiatrics and vascular surgeons started to become obvious and essential.
They realized they needed each other.
Exactly. Shared goal.
Yeah.
Save the limb. So they started sharing clinic space, sharing time in the OR, and importantly, sharing ideas and knowledge.
It seems like such a natural fit, given their complementary skills focused on the same problems.
Absolutely. And it became more formalized. In the U.S., a big step was in 2009 when the American Podiatric Medical Association, the APMA, formed an alliance with the Society for Vascular Surgery, SVS.
Okay, what were they aiming to do?
Pretty ambitious goals. Develop joint statements on best practices, create special journal supplements focused on the lower extremity, offer joint educational courses, work together on guidelines, and even advocate together for better patient care policies.
And did it work? Were they successful?
Yeah, quite successful, actually. One major output was the joint publication of 14 significant papers from top centers worldwide. That really cemented this idea of podiatry and vascular surgery as natural allies against amputation.
And that laid the groundwork for.
For the American Limb Preservation Society, ALPS, which formed in 2020, it's an even broader tent, bringing together all sorts of specialists focused on saving limbs.
So what does one of these effective CLTI teams actually look like? Who needs to be involved?
Well, to really manage CLTI well, you absolutely need a multidisciplinary approach. It's not just one or two specialties.
Right.
Typically, you need wound care experts, vascular surgeons for the blood flow, podiatrists for the foot structure and local care, infectious disease specialists if there's infection, and crucially, people looking at the whole patient.
Like diabetes educators,
Dietitian.
rehab specialists.
Exactly. Holistic care. It's not just the limb, it's the person.
And this team idea isn't brand new, right? I think I saw something about Dr. Joslin, the diabetes pioneer.
You're spot on. Dr. Elliot P. Joslin, way back in 1925, recognized how vital podiatrists were in preventing diabetic foot problems from getting out of hand. Truly ahead of his time.
Amazing.
He understood that cascade, sometimes called the stairway to an amputation.
Stairway to an amputation.
Yeah, it's a way to think about the progression. Starts with diabetes, which can lead to neuropathy, the nerve damage, loss of feeling. That increases the risk of unnoticed injury, leading to ulceration and open sore. Then ischemia, poor blood flow, hinders healing. Then often infection sets in. And without the right interventions, the final step can tragically be amputation.
That's a really clear, if grim, picture of the pathway. So how do the podiatrists and vascular surgeons fit into the team structure specifically? Is there a common model?
A model that's gained a lot of traction is the toe and flow model.
Would Chloe?
So toe is the podiatric surgeon focusing on the foot and ankle issues. Flow is the vascular surgeon dealing with the circulation. They form the core partnership.
Makes sense.
Other specialists are looped in as needed, depending on the patient's main problem. If poor perfusion, bad blood flow is the biggest issue, vascular surgery might take the lead initially. If it's more about infection or a complex wound with decent blood flow, podiatry might lead.
Flexible, depending on the primary issue.
Right. And the model often outlines different tiers of care, like basic care, maybe in a primary care setting, intermediate care with more resources, and then centers of excellence with the full multidisciplinary team and advanced capabilities.
So it adapts to different healthcare settings, but just having the team isn't enough, is it? They need a plan.
Absolutely. Effective teams need clear goals based on solid evidence. That means using established clinical practice guidelines, like the ones from the IWGDF, that international group.
Okay.
Those guidelines then inform local pathways, hospital policies, and importantly, quality assurance ways to track outcomes and make sure they're sticking to best practices.
So does all this effort, the teams, the guidelines, the collaboration, actually work? Does it reduce amputations?
The evidence is really quite overwhelming. The International Diabetes Federation, the IDF, states that over 85% of diabetes-related amputations could potentially be prevented by these kinds of podiatry vascular teams.
85%, that's huge.
It is, and study after study backs this up. We see significant drops in amputation rates when organized, team-based foot care programs are put in place. Some studies show reductions like 69% over 5 years or 72% over just 2 years. And it's not just amputations, ulcer rates go down too.
Those are staggering numbers. It really drives home the impact.
Totally. And if you look at meta-analyses, which pool data from many studies, they consistently show a clear benefit from team care in cutting amputation rates for people with diabetes and PAD.
And presumably this saves money too. Hospital stays for amputations must be incredibly expensive.
Hugely expensive. Inpatient costs are a massive chunk of spending on diabetic foot problems. Effective team care, following guidelines, often keeps people out of the hospital or shortens stays, which has major cost implications.
Wow.
The American Diabetes Association even has guidelines for inpatient foot care based on this idea of a diabetic rapid response acute foot team with specific essential skills needed to manage these problems quickly and effectively in the hospital.
So better care, lower costs. What about outpatient care? Does seeing a podiatrist regularly help prevent these issues from escalating in the first place?
Good question, and yes, studies show that too. Patients seeing a podiatrist regularly have lower risks of developing ulcers, cellulitis, or Charcot foot.
Okay.
Other research directly links consistent podiatric care to about a 29% lower risk of amputation and a 24% lower risk of being hospitalized for foot problems. That translates to significant savings.
Wow.
There was a well-known Canadian study comparing Calgary, which had an established vascular podiatry team, to Edmonton, which didn't at the time. Calgary had significantly fewer major amputations, real-world proof.
A clear demonstration of the team effect.
It really is, which also makes the flip side quite sobering.
What do you mean?
Well, the COVID-19 pandemic really disrupted a lot of this routine multidisciplinary care.
Ah, right. Access issues.
Exactly. And tragically, many places saw amputation rates go up during that time. Patients were also presenting later with more severe vascular disease. It got so bad that people proposed a specific pandemic diabetic foot triage system to help prioritize care during crises.
That's a stark reminder of how crucial consistent access to this team care is for these vulnerable patients. Okay, let's talk about prevention more broadly. You mentioned different levels.
Right. We generally think in 3 categories: primary, secondary, and post-secondary prevention.
Okay, primary first.
Primary prevention is for people who have diabetes, maybe with some nerve damage, neuropathy, or mild PAD, that's peripheral artery disease, poor circulation, but no open wounds or major current issues. The goal here is simple: stop the first problem from ever happening.
So what does that involve?
Regular screening for neuropathy and PAD, making sure they have the right shoes, protective footwear is key. Lots of patient education about daily foot checks, managing their diabetes well, and getting a comprehensive foot exam by a professional at least once a year. It's all about identifying risk early and acting proactively.
Got it. Address the risks before they cause damage. What about secondary prevention?
Secondary prevention kicks in when a major complication has occurred. So the patient has a diabetic foot ulcer, or Charcot foot, or gangrene, or a bad infection.
Go.
This is where that algorithmic, multidisciplinary team approach we've been discussing is absolutely critical. The goal is to manage the current problem aggressively and effectively to heal it and prevent limb loss.
Makes sense. And finally, post-secondary. What happens after, say, an ulcer heals?
Yeah, and we often prefer the term remission rather than healed.
Oh, why?
Remission. Because even after healing, these patients are at incredibly high risk of it happening again or having a new problem. The 5-year mortality rates for someone after a diabetic foot ulcer or amputation are shockingly high, comparable to many cancers.
Wow, I didn't realize it was that serious even after healing.
It is. For instance, about 50% of people will get another ulcer within just 1 year of healing the first one. And if someone has an amputation, there's roughly a 50% chance they'll lose the other leg within 2 years.
Those are incredibly sobering statistics, really highlights their ongoing vulnerability. So what's the focus of post-secondary prevention or care in remission?
It's all about preventing that recurrence or stopping new problems from developing. So strategies include things like very regular, lifelong podiatric surveillance, frequent checkups,
Okay.
maybe prophylactic surgery in some cases to correct underlying deformities that are causing pressure points, consistent use of specialized prescriptive footwear or orthotics. Some places even use technology like home temperature monitoring thermometry to catch early signs of inflammation before an ulcer forms.
Trying to catch problems really early.
Exactly. The ultimate goal is to keep the patient functional, maximize their ulcer-free days, keep them active, and preserve their quality of life long term.
This has been incredibly illuminating. A real deep dive into just how vital podiatrists are in this whole picture of saving limbs and improving lives for patients at risk.
Absolutely. I think the evidence we've discussed makes it crystal clear. These multidisciplinary teams, with podiatrists and vascular specialists working hand in glove, are not just effective, they're essential. Podiatrists bring unique, indispensable skills and knowledge in clinical care, in research, in education. They are truly paramount to limb preservation efforts.
So wrapping this up and considering all this compelling evidence for team care and prevention,
Yeah.
it really makes you wonder, doesn't it? What are the systemic hurdles still in place? What changes do we still need in our healthcare systems to make sure every patient at risk for limb loss actually gets access to this level of comprehensive expert care? That's definitely something to think about. Thank you for joining us on this deep dive.